a gentle request, like if you are not speaking, then keep your video and audio both muted and off, because otherwise it will distract the speaker.
So good morning in India and good afternoon in Australia. And we welcome you all to POSI webinar 27. And we hand over the proceedings to the President of the Paediatric Orthopaedic Society of India, Dr. Dhiren Kanjwala, to take it forward and introduce everyone.
Yes, good morning, my POSI members, and good afternoon, the experts from Australia. I welcome you all to the 27th Paediatric Orthopaedic Society of India webinar. This time the topic is comprehensive care for the obstetrical brachial plexus palsy. This webinar is really a unique webinar because till now most of the webinar had 1 or 2 experts, but this time we have 7 experts from Australia, and they are going to speak on complete care of the brachial plexus palsy. So I welcome them to our webinar. Just to give you the outline of the program, first of all, Dr. Brian Law will introduce his team and the topic to us. After that, we will have a set of first 2 lectures about the algorithm which they follow and about the microneural reconstructions. After that, we will take questions from audience on these 2 lectures. Then we will have a third and the fourth lecture on the tendon transfer and the osteotomies. And after that, those 2 lectures are over, we will take the questions from audience. Then we will take the last lecture, which is related to physiotherapy and the splints related to brachial plexus palsy. We have a unique moderator with us, Dr. Anil Bhatia, and he's one of the experts in the India on this topic, and he's going to share his lecture or his experience with us. And after his lecture, again, we can have a specific questions related to that. And lastly, our secretary will pass a vote of thanks. So with that, I now hand over to Brian to give an introduction of his team and to the topic. Over to you. Thank you.
Thank you. Thank you, Dr. Kanjwala. I'm just going to share my screen. Thank you for the opportunity and the invitation. Many of you are old friends of the Royal Children's, and I shan't belabor the points, but just as a brief introduction, the Royal Children's Hospital in Melbourne is 150 years old this year. We've had a long tradition of caring for brachial plexus patients. From the plastic side, from the plastic surgery side, we have Bruce Johnston, David McCombe, Chris Coombs, and today we also have Dan Wilkes and Will Alexander online with us. And then from the orthopedic side of things, I was very influenced by my late mentor, Ian Terrade. And the one important tradition for us is that the brachial plexus team has always been a multidisciplinary team. So it is run fortnightly. It's comprised of 5 plastic surgeons, 2 orthopedic surgeons, our brachial plexus coordinator and physiotherapist, Nicole Alexander, our hand therapists and occupational therapists, Rosemary Coe, and then we have the meerkats in the new hospital, which is now 10 years old, overlooking the room. As a bit of a guide, comparing our service with the rest of the service around the country, we receive between, now it's about 40 to 50 referrals a year, new referrals. We run our clinic fortnightly, and we see between 12 to 14 patients per clinic. We are the biggest service in the country. And our referrals have slowly increased, and it's reflective of the population growth in Australia. Thankfully, a lot of our referrals are still in neonates, with only a very small proportion of late presenters. Now, I shall not keep us any longer, and I shall pass the baton over to Professor Bruce Johnstone, who will give us a bit more of an introduction about the Melbourne perspective.
Thank you very much. I will just now share my screen here.
I'm Bruce Johnston. I've been involved in the obstetric brachial plexus palsy clinic at Melbourne's Royal Children's Hospital for 20 years. I'd like to give you an outline of what we do, why we do it, as well as some history, and this will be somewhat Melbourne-centric. We trace our historical origins in reconstructive plastic surgery back to the United Kingdom, and in particular Sir Harold Gillies. After the First World War, a young Benjamin Rank, a Melbourne surgeon, trained in plastic surgery with Sir Harold, and here we can see a photograph of Sir Harold having a cup of tea with the young Benny. Benjamin Rank became a military surgeon, and after the end of the Second World War established the first plastic surgery service in Australia at Melbourne's Repatriation Hospital. He trained many Australian surgeons, and here we see Professor Ian Taylor with Sir Benjamin enjoying a glass of Australian beer. About 20 years later, Ian's enjoying a glass of Australian red wine with myself. A lot of what we know about nerves and nerve injuries, as well as nerve surgery, comes from the work of Sir Sidney Sunderland, also a Melbourne academic. He trained in both neurology as well as surgery and was a highly respected anatomist. And he particularly outlined the internal structures of peripheral nerves, as well as clinically established a classification system for nerve injuries. He too was involved in treating returned soldiers with nerve injuries at Melbourne's Repatriation Hospital. I'd like to talk about two world leaders in the development of microsurgery from Melbourne, Ian Taylor and Bernard O'Brien. Sir Benjamin Rank was the first plastic surgeon at Melbourne's Royal Melbourne Hospital, and he also set up the Victorian Plastic Surgery Unit, a specialist unit at a new hospital in northern suburbs of Melbourne. Ian Taylor, as a young consultant in 1973 at the age of 34 at the Victorian Plastic Surgery Unit, performed the first free flap of skin using a groin flap, and this was published in the prestigious Plastic and Reconstructive Surgery Journal in August 1973. It was commented that 2 further cases were performed soon after, with the third case being performed by Bernard O'Brien in Melbourne. Ian went on to describe the free vascularized bone graft with successful cases, as well as free vascularized nerve grafts. Bernard O'Brien did a lot of research and experimental development of microsurgery in the 1960s and was well placed to also perform a free groin flap to the foot, and this was published a month later in PRS with co-authors particularly Alan McLeod and Wayne Morrison. They went on soon after to report a vast clinical experience with replantation. St Vincent's Hospital was the replantation service for Victoria for many, and with Bernie's research and clinical experience, he trained many microsurgeons and established what is now known as the Bernard O'Brien Institute. Here's a photograph from the 70s with Alan McLeod and Wayne Morrison, who were involved in Bernie's first free flap. Also on the Wall of Fame here is a young Alain Gilbert, who in 1973 was the microsurgery fellow. Alain Gilbert returned to Paris and started doing nerve grafting for infants with Erb's palsy, and first published his experience in 1980. This is a photograph I took of Alain Gilbert at a meeting in Sydney in 2007, talking to Hanno Malaysi, the father of nerve grafting. This publication in 1988 by Gilbert's group reported the long-term results of a large number of children undergoing nerve grafting, and this is really a game changer. Here's a brief summary of the abstract. I'm going to read you most of the full abstract because there is such worthwhile material here. This is really the essence of what we do, and it has changed very little in 32 years. The present series is the first one with long-term results of a large number of patients. Most publications give short-term results of a few cases. As a result, it is difficult to compare these results with anything but spontaneous recovery. In C5-6, in other words, Neurachus upper plexus injury or group 1, at 5 years, we found 80% of good or near normal results compared to 0% in spontaneous recovery. These figures are 45% versus 0% in C5-6-7, in other words, Neurachus extended upper plexus or group 2. Of course, at 5 years, the patients in this series have benefited from secondary tendon transfers. However, it is an advantage of the operated cases that their transfers are made possible by the recovery of shoulder muscles and the absence, in most cases, of the typical co-contractions that occurred with spontaneous recovery. Subscapular releases were done 27 times for internal rotation contracture, and latissimus dorsi transfers in 35 cases. The indication for surgical repair of the obstetric palsy remains the absence of recovery in the biceps muscle at 3 months. The surgical treatment includes the initial plexus repair and the subsequent operations of joint release, muscle transfers, and this needs to be done at an early age. In Melbourne, Jane Bartlett was the physiotherapist involved in treating children with brachial plexus palsies, and she encouraged a young Keith Mutimer, who'd returned from training overseas, very skilled in microsurgery, to start doing nerve graft work, and he started the brachial plexus clinic with Jane in 1988 and continued until 2000. He became the president of the Australian Society of Plastic Surgeons, and I then took over the clinic. Ian Terrade was the orthopaedic surgeon involved in these patients. He had a long-term interest in the shoulder, and in fact he and Mark Hoffer from Los Angeles were the only two surgeons worldwide who believed that there really was a problem with the shoulder in these patients. At that time, the interest was really in achieving some elbow flexion. Lee Coleman, a radiologist, was involved in MRI from its beginnings, and she and Keith worked together to establish MRI as the investigation to look for nerve root avulsion in these patients. Prior to that time, the standard investigation was the somewhat invasive CT myelogram. We put together an information booklet for parents, and once this was published on the Royal Children's Hospital website, it became available worldwide, and this led to referrals, particularly for second opinions, from interstate. This book has some wonderful illustrations done by Bill Reed, our medical illustrator, showing the normal anatomy of the plexus as well as the internal structure of peripheral nerves. Fortunately, the majority of patients have spontaneous recovery, and Erb's palsy or brachial plexus palsy appears in about 1 in 1,000 births. And this is a fairly typical finding in one of our patients undergoing surgery. We had an interest in the histology of the specimens resected, and for comparison, here's a normal nerve, here's a somewhat scarred and disorganized histological section from the mid-upper trunk in one of these patients, and then the last slice that's taken from, in this case, the C5 proximal nerve root shows relatively normal structure compared to a normal peripheral nerve. And this represents what is the commonest reconstruction that we perform, a transfer of the accessory nerve to the suprascapular, as well as a number of sural nerve grafts to bridge the gap once the neuroma is resected. Howard Clark and Christine Curtis, a physiotherapist from Toronto, developed the active movement or AMS scale, which is a 0 to 7 scale for muscle charting in these patients. And the difference from the standard scale is that there is a score for more than or less than half a normal range, both with gravity eliminated as well as against gravity. And one needs to score a 4 before one can achieve higher scores. Here is an example of an assessment of a child with a fairly severe brachial plexus palsy, and you can see the scoring here, as well as the passive range of movement being assessed. And shoulder external rotation is limited to 50 degrees in this patient, and elbow flexion is scored as a 0. There is some active elbow extension, so this child would be considered to be an upper palsy or a Neurolysis number 1 in his classification. So there is some triceps suggesting that C7 nerve roots at least partially intact. And there are clear indications for this child to proceed with reconstruction. So the indications for surgery are a total palsy, particularly if there's a Horner syndrome, so Neurolysis grade 3 and 4 if you include Horner syndrome. And following on from Alain Gilbert's work, no biceps contraction between 3 and 4 months of age. And if there is some activity within the biceps, you then watch the trends with serial assessments using the Toronto AMS scale. And by 9 months of age, the child should be able to place a biscuit within their mouth, and this is called the cookie test. And this tests not only for elbow flexion, but also for supination, as well as to some extent external rotation required to achieve this. And if they are planned for surgery, we would then book an MRI scan to look for evidence of nerve root avulsion. And most patients need both sural nerves harvested for reconstruction. I'm going to show you my first case that I performed surgery for in November 2000. So this girl was born at 40 weeks gestation with a insulin-dependent diabetic mother and a weight way over the 90th percentile at 4.74 kilograms. She had severe shoulder dystocia, required vacuum extraction, and had a total palsy with. This is the clinical appearance of the arm, and you can see on the serial Toronto scales that elbow flexion was scored initially as 0. Interestingly enough, a 5 was scored at 11 months of age, and ideally this patient would have had surgery probably at about 3 to 4 months of age. However, it was a time of transition as I was starting to work in the clinic. And here is the MRI scan showing the pseudomeningocele, which was reported to be found from the level of C6 down to T1. There was also significant posterior subluxation of the humeral head. Only the C5 nerve root was found to be not avulsed, and we proceeded with a accessory to suprascapular nerve transfer, as well as nerve grafts to the upper and middle trunk, as well as a long nerve graft through to the medial head of the median nerve. And because of her shoulder fixed internal rotation, a subscapular release was performed. And here we can see the nerve grafts in place, as well as the accessory nerve transfer. Elbow flexion was lost, as one would expect, immediately after surgery, but reappeared at 6 months of age, and by 2 years of age this patient has had pretty good recovery in most muscle groups. Here we see her 2.5 years following the surgery. She still has some restricted external rotation of the shoulder. The scars on her legs are quite acceptable, as well as the deltopectoral incision used to access the shoulder, as well as the distal plexus. The scar in her neck is imperceptible. These videos show our patient at 2.5 years following surgery at the age of 3.5, as well as more recently at the age of 20. And it is remarkable that all of this function in the left upper limb is coming through one nerve root, the C5 nerve root, through a number of nerve grafts, as well as the suprascapular nerve transfer that's been achieved using the distal accessory nerve. And despite the initial stiffness in her shoulder, she does actually have a really good range of active external rotation, as well as good control of her wrist, fingers and thumb. And she tells me that she has no functional problems. She's a well-adjusted young lady and is not even concerned about the cosmetic differences between this upper limb. And she describes her left hand as a very useful helper hand. It's certainly not perfect, but she has got on well with her life and her studies as a educationalist. So what do we do? And this is a slide from a talk I gave over 10 years ago. We spent a lot of time observing the patients at play and with various activities in our clinic. There's a lot of discussion and thinking as a group activity. And our clinic is staffed by surgeons, both orthopaedic and plastic, as well as physiotherapists and occupational therapists. And we do our very best at all stages of care. And we have a positive, somewhat future-focused team creating a well-resourced healing environment. And our booklet, our patient information booklet, has resulted in quite a well-established network within Victoria, but also across Australia. And I think we communicate well with all of our stakeholders, and we do offer a perspective that it could have been worse. In particular, if a child being delivered with shoulder dystocia, which is an unpredictable and rather terrifying obstetric emergency, is not delivered promptly, then severe brain damage or death would certainly result. And I think through these approaches we have reduced what was a bit of litigation that we saw some years ago. And so thank you for your attention. I hope this has been helpful.
Next up, we have Dr. McCombe, or Mr. McCombe, who's also a plastic reconstructive surgeon from Melbourne.
My screen has just disappeared for some reason. I'll just see if I can. There we are. So I will just share my presentation on our algorithm for that's the wrong screen, sorry. Here we are. Algorithm for nerve reconstruction in brachial plexus birth palsy. I'd like to thank the Indian Society for inviting us to present our work to them, and a lot of what I have to say will echo what Bruce has already spoken about, but I guess it's just codifying what our approach is in the current environment. So the difficulty, I think, with brachial plexus palsy, or the difficulty with all closed nerve injury, is trying to assess whether treatment is indicated or not, or whether there's potential for spontaneous resolution. And this is particularly the case in birth palsy, where it's a relatively low energy injury, and you would expect the prognosis of the injury to be quite good, and that's borne out by the numbers of most children present. Most babies who present do recover spontaneously, often early and without significant consequence. Although I think if you look closely at your cohort of babies presenting with this injury, that while their recovery may exceed the they may recover to the point where they recover elbow and shoulder function, there can still be long-term consequences of the injury, which I think we sometimes underestimate. So the big question in my head and in all of our heads is treatment in the form of surgery, microsurgery, nerve reconstruction indicated? And to answer that question, we really need to establish what the prognosis of the injury for the individual is. And we also need to have a good idea of what the outcomes of our intervention are, and when it's likely that our surgical intervention will exceed the child's own intrinsic capacity for recovery. So to try and work out what the prognosis of the brachial plexus birth palsy is, it's a matter of going back to the natural history of the injury. And for that, we owe, and this is echoing Bruce's talk again with respect to Sir Sidney Sunderland, who's there on the right, and Herbert Seddon on the left, and their concepts of the extent of the axonal and neural injury with the gradation that Bruce mentioned before. And it's really establishing where the child's injury is in this spectrum, and whether for the neuropraxic injury, which you would expect an excellent recovery, or perhaps a grade 2 axonomesis injury, rather than, which again you would expect a reasonable recovery from, compared to the more severe forms of neural injury with disruption of the associated soft tissues around the nerve itself, and consequence with scarring and limitation of regeneration. So how can we don't have imaging which allows us we don't have adequate imaging, which will distinguish these grades. So we're really dependent upon our clinical assessment. Neurophysiology can help. Imaging can be of some assistance in the more severe end of the spectrum. And these are the types of assessments that we do for all peripheral nerve injury. But in the child or the neonate, we are limited with respect to our clinical assessment, mainly to that of observation. And this is where Howard Clark's active movement scale is an elegant demonstration of this, and something we adhere to. We rarely use neurophysiology in our clinic. I personally find it either overestimates or underestimates the injury, and I think serial observation is far more accurate. And the role of imaging is really that once we've made the decision as to, on the basis of the clinical picture of the progression of recovery or lack thereof, as whether we're going to go ahead with surgery and using imaging to help guide that. The interventions we have are either non-operative intervention with physiotherapy and or splinting. And then with respect to operative interventions, it's the list on the right with Neurolysis, which I personally don't think does very much, and there's some literature that would support that. In contrast, perhaps to excision of neuroma and either nerve grafting or reinnervation using nerve transfer. The use of muscle and tendon transfers and osteotomies is a secondary strategies for dealing with this. So we're really talking about the reinnervation of the plexus using exploration, identification of neuroma and grafting, or bypassing that step and going directly to a selective nerve transfer, depending on the circumstance. To work out whether these things work, we need to be able to measure outcomes, and this is where it gets confusing from my perspective. We have the Mallet score of shoulder function, which has been a mainstay from the early 70s. The active motion scale of Clark and Curtis, which helps us with our observation and grading of change. And then there are Raimondi's scale of outcome, the hand and wrist, and elbow function. And then more recently, a patient-rated outcome scale, the BPOM. And I think an exciting development is the iPluto group, which is looking to try and standardize our assessments of these patients. And I'm sure that there'll be centers within India who'll be participating in this. And I think this is a really important initiative from Willem Pondag and Malaysia in Leiden, amongst others, that to try and standardize our approach so we can get some true data about where we're going to with our interventions and outcomes. If we look at what we've got, we have Gilbert and Tassan's work on which Bruce mentioned, and based upon making a decision about prognosis based on the absence or presence of elbow flexion at the age of 3 months. And they showed some certainly improvement in the upper trunk and C567 group compared to who had surgery compared to non-operative patients. Clark and Curtis from the early 90s using their active movement score to object to substratify their patients. They came up with a list of poor predictors or predictors of a poor result at both 3 months and 9 months. And we largely adhere to these or have adhered to these as our indicators. And the point I made before about neurolysis being not particularly effective, that was one of Howard's early papers, which I would agree with as well. Peter Waters looked at his own patients and stretched out that 3-month indicator to more like a 4 to 5 month indicator as to what the absence of active elbow flexion being an indicator of poor recovery. And I would perhaps agree with him that I think that there are patients who have poor elbow flexion at 3 months or zero biceps at 3 months who subsequently do recover good function, and I think we can stretch it out to a slightly later age point. The other thing that's sort of happened in parallel with this assessment of outcome is the advent of nerve transfers, and Christoph Oberlin while nerve transfers have been around for 100 years, they exploded really in terms of popularity in peripheral nerve surgery from the early 90s onward, when Christoph demonstrated exciting results with elbow flexion in adult population. And they have been, and they're now absolutely accepted as the strategy for treatment of adult plexus injury, or labels. And I guess the question is, will they have the same advantages in that group that they do in the adults? The data is mixed. I think that the graph versus nerve transfer in accessory suprascapular, our own paper there is Surya in 2015. We demonstrated better results in nerve transfer reinnervation of suprascapular nerve versus grafting. Others have used it for more extensively within plexus reconstruction, adding more distal transfers for elbow flexion. But by and large, the results, as stated by the last paper there, particularly for elbow flexion, are relatively equivalent. And I think that it's a probably more nuanced employment of that technique, which is the technique of transfer versus grafting, which I think I'll talk about some more in a moment. So in terms of algorithm, we have tried to develop a systematic approach to our collection of data, assessment of time points, and then approach to individual treatments, so that we can try to get better information as to whether we're actually doing some good for these children or not. So we've come up with this strategy of regular early assessment, trying to see the babies initially before 6 weeks of age, try and make an assessment at that stage whether we're dealing with a total or partial plexus. As Bruce said before, if we're dealing with a total plexus, we'd like to get on and do surgery early. The later the upper trunk or partial plexus injuries, and then go through a monthly assessment until that 4 to 5 month period where a decision can be made about whether they should proceed with early surgery. In the equivocal group, we go to the 9 month mark and do a cookie test, and then based on that, make a further decision. And then in more recent years, we've been looking at the selective failure of recovery of external rotation as a further indication for external rotation nerve transfer with accessory suprascapular transfer done at around the age of 12 months. So as I said, the panplexus injury requires early surgery. We do an MRI for looking for proximal root integrity. These children do undergo supraclavicular exploration. We look for what axons are available, and particularly it's usual, I think, in these children, even with a devastating injury, that they do have some proximal roots available, as Bruce's case illustrates. I know Alexander Mutse is online, and I know has some experience with extraplexal donors, particularly with cross-neck transfers, and I'd be interested to hear what he has to say about that. I think it's important to prioritize hand function in terms of distal targets, and then elbow function and perhaps shoulder can be sacrificed to some degree depending on what you've got available. For the upper trunk lesions, if it's clear that the prognosis is poor, then early surgery. We use a dorsal approach to do accessory to suprascapular transfer. I do have some hesitation about the impact of accessory nerve transfer as a donor site, but that's perhaps for another day. In the early patient, the patient we're operating on at the 4 to 5 month mark, we would do a supraclavicular exploration, neuromer excision and grafting. but I guess what I would do now that I perhaps didn't do when I started doing these is that I would be fairly careful in my evaluation of the nerve roots. And if I was concerned about quality of nerve root, I would employ a oberlin transfer distally for elbow flexion so as to preserve the better quality roots for the shoulder and perhaps triceps and radial function. So I'd be happy to do both a combination of grafting and nerve transfer in this group, depending on what assessment I could make of the quality of the nerve roots available at the time. In late surgery, with those presenting with who had presented late or had a plateaued their early recovery and hadn't gone on to recover adequately, I'd be more tempted in these children to go with a transfer-only approach with a dorsal accessory to suprascapular approach, oberlin transfer, either single or dual fascicle, depending on what function had recovered, and then triceps to auxiliary for deltoid, on the basis that the child who's having recovery at this late stage, the nerve transfers, one advantage that has been demonstrated is earlier recovery, and I think this is important to minimise duration of denervation of these muscles. So that's the approach that we are using at the moment. I think we were going to pause here for questions. Is that correct, Brian? Were we going to pause at this moment?
Yeah,
for
yes.
questions? Is that right?
Sorry. I think Dr. Shah is going to ask some questions.
Okay.
Yeah, so I thank Bruce and David for nice talks, and we have a couple of questions from audience. The first one is for Bruce, that you have seen very long-term outcome of your nerve surgery patients. Do you see deterioration of upper extremity function due to increase in the size of the upper extremity and increase in the weight of the arm? And what do you suggest them in rehabilitation to keep their earlier function to be permanent?
Well, I've been involved in the clinic for 20 years, and I can't say that we've seen much in the way of deterioration. It's a very interesting thing to follow kids through into their adolescence. And you do see psychological problems developing. You see often non-specific pain, which does need some investigation or consideration. But in terms of significantly losing function due to the weight or increased bulk of their upper limb, there seems to be not a bad sort of proportion between their development of muscle bulk and the weight. We're very carefully watching kids as they go through growth spurts, and that's when you can see, say, an elbow fixed flexion deformity developing fairly rapidly, but their muscle strength seems to hold out pretty well. Maybe Dave could make some comments about this as well.
Right.
Yeah.
Yes,
Sorry.
Dave, please go on. Yeah.
Sorry, I'd agree. I think as kids get to adolescence, they do develop more shoulder pain, or they're more willing to report shoulder pain. And some of that's postural. Some of it's probably a consequence of premature degenerative change, perhaps with the kids who've got the worst glenoids. There is, Alain Gilbert reported many years ago about a loss of internal rotation of the shoulder over time, and I think that occurs. Look, I think it's, there is deterioration in the, or there's perhaps not deterioration, it's not quite the right word. There is I think the kids learn or become more aware of what their deficits of function are sometimes, and that's manifest in different ways, and that's an individual thing. But I think the true sort of post-nerve injury functional loss probably takes longer to manifest. I think that's more something that we might see in our 30, 40, 50-year-old patients rather than our 15, 18-year-old patients. And this is why I think this sort of systematic data collection and follow-up will be really valuable over time if we can manage that. So, yeah, that's why I encourage everybody to try and keep great records and get on board with these international efforts of data collection.
Alex is on our panelist list. Alex, do you have any comment on this question? What you have seen in the long term about, is there any deterioration of existing function? Is Alex there? Or he's in? Yes. He's there.
I am here.
Welcome, Alex. Good morning.
Thank you very much. Well, the question of glenoid deformity and the painful of the shoulder is that if you don't prevent very early, then it's very difficult to stop since the beginning. So the work of the fathers, even if you do a very nice surgeries or you do nice procedures, has to be very active. And the release, we do it very early. And we do all the procedures very early and all the glenoid remodelation before the 3 to 4 years. And sometimes when we see that it really goes very backwards, even if it's very early, we try to push and to remodel the glenoid from the posterior osteotomy and leave it when the angles goes very far away. So probably the answer is to have a good follow-up of all these patients, is to do it very early, everything, and be very active on that, and to push very much on the families, which is not very easy in the different countries. Because sometimes you do very nice work, but people cannot follow perfectly. So thank you all for the work.
One more question is for David, and then Bruce can also find about that there are sometimes severe internal rotation contracture development earlier on, or what we term as infantile subluxation. And that situation makes assessment of anti-gravity biceps difficult. So have you come across that situation because of significant internal rotation contracture, you are not able to assess biceps adequately? And so you prefer to treat that contracture first and then consider biceps assessment later. So what do you do in that situation?
I think when we've seen that, it's still been evident. Those kids, I think, have got a significant injury and they've had a significant period of denervation, which goes to contracture development. And when we've seen that, we've done, as Bruce pointed out in that early case of his, we've combined the nerve reconstruction with early joint release, as Alex was saying, which I absolutely think is the key. I think we've really got to get the shoulder concentric and balanced as early as we can. I haven't seen it as a thing that precludes the assessment of elbow flexion as such. I think it's probably a marker of severity of injury, and it's the sort of thing that would push me more towards doing surgery earlier than later. I don't know what you're feeling, Bruce or Alex, with that. I think that bad internal rotation contracture early has to be addressed, and has to be addressed fairly aggressively to make sure that
we see few children presenting with posterior subluxation or dislocation at the age of 4 or 5 months, and those are the real queries. Alex, your thoughts on this?
Well, I think that it's absolutely mandatory to assess internal rotation problem. This is one of the emergencies in OBP. I think that we have two different things. One is a paralysis, which is very emergently to operate at 3 months. And the second is the bone deformities and the articulation deformity that should be assessed immediately. So there's no point to feel that difficulty about assessing biceps because of the contracture, because the problem is the contracture of internal rotation immediately. So this is clear. Yeah, for me, I agree with him.
I think we don't often see early internal rotation deformities. I think we're very fortunate in that the patients are referred to us quite early, mostly in the first month or two of life. And we have a wonderful team of occupational therapists and physiotherapists, and the parents are instructed to passively externally rotate the shoulder as soon as the contact is made. And I think that's very successful, but we do watch out for it. And particularly in the first year or so of life, if we do start to see an internal rotation deformity developing, we would consider giving them a brief general anaesthetic, Botox, manipulation, and casting them into an externally rotated position for a month or so. And that sometimes produces a dramatic result. Sometimes it produces a good result for a few months and then they recur. And ultimately these kids need to have shoulder surgery. But I think Botox and manipulation and casting is a very useful thing. But I think preemptively, by having the physiotherapists instructing and reviewing our patients frequently up to the time of their nerve grafting surgery and then beyond, we don't see too much of a problem in that first year of life. And we would like to think that by maintaining a good passive range of external rotation, we're not seeing so many posterior subluxations, and hopefully we're reducing the extent of glenohumeral deformity. But once again, it's a great subject for some future research.
Right. So I think we have many talks remaining. So I'll invite Brian to introduce the next talk. We'll proceed to the next talk.
Okay. Let me just get the next talk up. Oh, hang on. Can I, sorry, I've got a bit of I'll end that one and I will start my next talk. Have you got that on screen?
Not yet.
Not yet.
I'm doing two talks.
Here it goes.
Excellent.
Code grey is
Code grey. So to follow on, I think that we're in Melbourne, we've got a luxury really that we're able to, we're a pretty well-resourced clinic, and we have the luxury of being able to follow these kids pretty closely. And I certainly would implore anybody who wants to do this, get involved in this, to try and set up their department to be able to review the children regularly so as to pick up the circumstances where this, these interventions are required, because I think it's clear that the earlier you deal with things with these kids, the better, because of the impact that growth and persistent malalignment of the shoulder in particular and elsewhere has on the child. So tendon transfers for a well-balanced shoulder is the next topic. And so the consequence of nerve injury, as we know, is a palsy, sensory deficit, pain, and in the neonate, we have the added impact of development of contracture with consequent joint dysplasia, and in the most severe injuries of limb neglect. There's Roger Cornwall from Cincinnati has done a lot of animal work looking at the etiology of the muscle contracture in brachial plexus palsy, and his current theory, at least, is that the impact of neonatal muscle denervation leads to an relative increase in muscle degradation, which reduces muscle growth, reduces sarcomere numbers and elongates sarcomere length, and that leads to a muscle contracture with consequent joint contracture. And that leads to an unbalanced joint with impact upon the growing joint, consequence of joint dysplasia, and that's well demonstrated in the glenohumeral joint in particular. The consequence of that is loss of function. So for the shoulder, loss of active external rotation, abduction. And the question in the longer term is the premature degeneration. And I think we do see some impact with pain in the adolescent due to that. This is a photo of an untreated patient who, or I think he'd had a shoulder release at some point, but had late treatment. He has got obviously a small limb, contracted, reduced, significant reduction in function. And this is the sort of thing we're trying to avoid. So the contracture and joint dysplasia, the aims are, as Bruce was highlighting, is the idea of prevention. And I think re-innovation is critical in that role of both maintenance, attempt at least to maintain passive range of motion, and splinting is valuable in the distal contracture, perhaps not so much around the shoulder. Treatment of the established contracture or the early contracture is either with surgery or potentially with the assistance of Botox. And then I think in addition to releasing the contracture, we need to rebalance the forces around the joint by tendon transfer. At the shoulder, we see children presenting with this internally rotated posture, which leads to a significant degree of asymmetry. They, in addition to having the internal rotation contracture, have a abduction contracture often, which has consequence for scapular stability and malrotation, and with passive restriction of motion with internal rotation contracture and abduction contracture, and then limitations of active motion, both of abduction, external rotation, and also internal rotation as well. Contracture release, I guess the question in the established contracture, whether physiotherapy and Botox, what that actually does. And I think physiotherapy has a critical role in maintenance of existing range of motion, but whether in the child who is destined to go on and develop a contracture, whether that's going to, what sort of impact physiotherapy has on that is I think unclear. And we have used Botox, and as Bruce suggested, there are patients for whom we feel that it makes a substantial difference for combination of Botox, particularly Botox and casting. But again, I don't know that there are patients for whom it probably hasn't made as much of a difference as we would like. And when you think about what the Botox is doing to these muscles that would appear to be structurally perhaps altered by the denervation, the consequence of denervation as a primary thing, as to whether we're changing the muscle length substantially enough to avoid contracture and avoid the impact upon joint anatomy is I think unclear. And again, an area where there's opportunity for more study, I think, would be my feeling about Botox. I think surgery does work. It's hard to find. I was looking through all my slides of subscapular releases and anterior releases of the shoulder. It's a pretty hard operation to take an effective photograph of because it's down the bottom of a deep dark hole. We tend to use a subscapularis tenotomy. I have done subscapular slides of the origin of the muscle from a lateral approach. I know that there's significant experience in India with a medial approach that's been described. I've tried that once with a patient who was having a dorsal accessory nerve release at the time, and I think that probably achieved some advantage. The question is whether you do an anterior capsulotomy. I think depends upon what sort of passive range of motion you can achieve with your subscapular lengthening, whether it be by tenotomy, which is my preference, or slide of the muscle origin. I don't have any experience with arthroscopic capsulotomy. that was, and I don't know whether Alexander, whether you do that or not, but I think that has potentially some advantage. It certainly was popular when in the 90s when it was first talked about. The abduction contracture component of the shoulder contracture, I think, is really challenging, and I don't have an answer for that. We've tried lots of physiotherapy. We've tried, Brian, who's speaking later, has tried some supraspinatus slides and capsular releases, but I think that's a difficult thing, and it may be something that's better addressed by a corrective osteotomy down the track. But again, that's not clear to me, at least at this point. So after the passive range of motion of the shoulder has been restored, the question about rebalancing is what the best approach to that is. The muscle that we tend to use most is a latissimus dorsi. I have gone through phases of using combined latissimus dorsi and teres major or latissimus dorsi alone. I think I prefer the latissimus dorsi muscle alone, given it's independent of the scapular position. And I think, at least theoretically, should allow better internal rotation of the shoulder afterwards. The other point, I think, is where you actually put it and how you achieve adequate coaptation. I've used all three of those options. I think as I've matured a bit and started to operate on these kids earlier and earlier, I have avoided anchors because I just don't think they give you adequate hold. I think transosseous suture is valuable, and some sort of coaptation into the tendon, weaving it into the tendon of infraspinatus. And again, it's a question of where you put where you insert the latissimus. I think there's there are things to learn about how trying to get it perhaps as high as you possibly can on the greater tuberosity into the infraspinatus insertion, I think, is valuable in terms of preserving the range of abduction. I think if you put the tendon too low in the infraspinatus tendon, or if you even get it lower and have your latissimus inserting as low as the teres minor insertion, then that's only going to produce an adduction moment at the shoulder, and I think that is counterproductive. Whereas if it's high on the greater tuberosity, it pulls the humeral head down as a humeral head depressor and helps with abduction, or at least preserves abduction. So I think there's some nuances in terms of these points that of technique that help you try and produce or helps you get a reproducible result with the surgery. And each time I do the procedure, I sort of try to replicate what I did last time, but this is not an easy operation in my mind to get perfect, I think, but there's a lot riding on it, so it's worth the effort. So the outcomes of the shoulder surgery, the improvement in function that we can achieve is improving active external rotation, supination, reducing the Clarion sign. I think sometimes you can improve abduction. I think you certainly improve external rotation in the abducted position better than you improve the external rotation in the adducted position. I think that it's a very effective transfer for improving above shoulder reach, but it may not make a dramatic difference in a mallet scale assessment. It's sometimes disappointing when you rescore these kids that their outcomes aren't as dramatically improved, in at least in my way of thinking, as I was expecting. Although the patient themselves reports that their function's much improved because their ability to reach with external rotation, the abductor position in particular, and to extend their shoulder, put their hand behind their head, is much improved. The question, I guess, with respect to long-term results is something we've touched on before. In Australia, there's a lot of emphasis on swimming and access to pools, and the beach, obviously, I think that helps. I think encouraging these kids as adolescents to continue to to exercise and do upper body activity helps maintain the benefit that you get. I think Gilbert published a paper which suggested the results of the transfers deteriorated over time, but that hasn't really been our experience. Perhaps we've been lucky. So the other question with respect to outcomes is the impact upon the glenohumeral congruity. There is plenty of work that establishes that the consequence of rebalancing can be to remodel the glenohumeral relationship, and I think that's important. The question is for the child who has the established glenohumeral deformity as to where the threshold for soft tissue surgery versus osteotomy is, and certainly a type, this is a Waters classification of glenohumeral dysplasia on your right, certainly a type 4 or greater is, in my hands, in the established glenohumeral dysplasia is beyond what we can help with soft tissue surgery, I think, and that's more an osteotomy province. I think the earlier you're dealing with the child, the better your opportunity to achieve remodeling, and certainly children demonstrating changes of 2, 3, and 4, we would be very keen to get on and deal with their shoulders with the rebalancing procedure and with the aim of trying to remodel the glenoid. Thank you very much.
All right. Well, I'll swap over. Thank you, Dave. And I'll just start my screen share. So good morning, everyone. Thank you again. My role in the brachial plexus team here in Melbourne is one of the orthopaedic surgeons, and I suppose I come at it from a slightly different angle, and I'm very much a bony surgeon rather than a microvascular or nerve surgeon. So my aim today is to talk you through our local experience with the redirectional osteotomies for brachial plexus in the glenoid that were first described by the team at the Sick Kids in Toronto. So while some recent heads of state have dragged golf into disrepute, I like to think of the shoulder joint still as that big golf ball delicately balanced on a very small tee. If the golf tee is broken or bent, then the ball isn't going to stay balanced, it's just going to fall off. But somehow if we could straighten or fix that broken tee, we could potentially get it to sit up and balance again. Now, in my head, the surgical treatment for secondary shoulder dysfunction in brachial plexus palsy tries to achieve 3 goals. David, Bruce, and Alexander have already started discussing and covering the first 2 points. So my main thing is to focus on that third bit, the realignment of the dysplastic glenohumeral joint. You know, I think we're all increasingly aware of glenohumeral dysplasia. We recognize that the retroversion, the pseudoglenoid, and the subluxation contributes to the static joint deformity. And we now recognize that muscle rebalancing surgery, it halts the progression of dysplasia, but does not allow for significant remodeling in the older children. Now, if we look at the literature, so especially the Boston and Scott Cozen's group as well, with their papers in 2009, 2010, when they talk about early rebalancing of the shoulder to get the remodeling, the average age of surgery for those patients was 2.6 years. When I was talking to Howard Clark in one of his more philosophical moods, he would look at me with a cheeky smile and say, maybe we should just abandon nerve surgery and start tendon surgery even earlier. So if those goals cannot be accomplished, we know that palliative osteotomies of the humerus to externally rotate can improve shoulder function. Whether you perform it proximally or distally, it has previously been the only surgical option for us in patients with that severe glenohumeral dysplasia. We need to be cognizant that these osteotomies don't increase your existing arc of movement. They just transpose that arc to a more functional range. So you're robbing Peter to pay Paul. Now, I had the pleasure of working with Sivan Hopian and the very brilliant Howard Clark while on fellowship at the Sick Kids. It has been, and still is a big referral centre for neonatal brachial plexus palsy. Lots of well-established treatment pathways, very experienced people. But despite reducing shoulders and performing shoulder balancing surgery very early and very proactively, there were still lots of persistent Warsis 4, Warsis 5 type glenoids. Now, in the 5s, with their flattening of the humeral head, we were a bit more pessimistic, but we thought in the 4s, especially the slightly older kids who had missed that window on remodeling, maybe we could do something. So then in a bit of a paradigm shift, we turned the attention towards the glenoid. And Sivan's hypothesis was that if you had that sick joint, if you reduce the shoulder, correct the version of the glenoid, that would contribute to the stability once you've done balancing. So as an analogy, I'm a DDH surgeon, it's my other love. With hip dysplasia, we know that open reduction and soft tissue procedures are sometimes not enough to maintain the hip reduction, and you need the acetabular osteotomy as well. Most of us know, and we all know how important it is to intervene in a timely fashion, as we've heard earlier on. And especially those with neuromuscular practices, you're all too aware of the bony deformities that you get when muscles are imbalanced. So, I did my fellowship in Toronto, the home of Salter, the home of the redirectional osteotomy. So why not try it in the shoulder? So I'll digress a little bit. The pathoanatomy. We know that concavity compression effect of the cuff and the dynamic stabilizers. As a child grows, centers the humeral head. It increases concentric glenoid depth with growth. The most widely accepted mechanism is that the pathologic force vectors from active and strong internal rotators and paralyzed external rotators lead to the joint contracture and the bony deformity. New motion analysis studies have suggested maybe it's more a functional ankylosis of the glenohumeral joint in all directions. It's more consistent with contractures of everything. And this probably helps explain those paradoxical contractures, like the abduction contracture that Dave was talking about. Now, we touched on very briefly, so Roger Cornwall's work at Cincinnati Children's, he implicates impaired growth and development of that neonatally denervated muscle in contracture pathogenesis. So I think the interplay between denervation, muscle atrophy, and musculoskeletal growth is much, much more complex than I can truly understand, or maybe anyone can understand. And that we also need to recognize the shoulder contracture is also more complex than just a unidirectional internal rotation contracture. There's also different planes that we need to think about. So if we redirect the joint, add a subscapularis slide, as well as transfer teres major and latissimus dorsi, maybe we can achieve all of those 3 surgical goals in the older child. And maybe we can increase the arc rather than just transposing it. And I'm a bone surgeon and I understand bone best. So osteotomies, that's more my comfort zone. So how do we do it? Well, place the patient lateral and bean bags I always send the anaesthetist down to the foot end so that I don't have to deal with them. And I place the patient on the radiolucent end just in case. Then it's an L-shaped incision with one arm along the scapular spine, and then it turns down to come down the posteromedial aspect of the humerus into the axilla. Then you carefully raise an inframedial fasciocutaneous flap. I find it always gets stuck at the inferior border of the posterior deltoid. And then I lift the deltoid off the scapular spine from medial to lateral. And in this age group, when they're about 4 or 5, we do it subperiosteally, and then as they get older, we use an osteotome to take the slivers of bone. Then I aim to do the subscapularis slide, and that's from the back. I find the superior edge of the teres major, pull it inferiorly with a retractor, and I find the infralateral edge of the scapula. Just use the cautery to incise through the fascia, and then I use a Cobb elevator to perform supraperiosteally, just a lifting up of the subscapularis while the shoulder is reduced, hopefully. So you adduct, externally rotate and run your Cobb and try and get through. Now, in Toronto, much more skilled surgeons than me, they would quite comfortably get all the way medially, but I've taken to using a small percutaneous window like Dr. Shah described in his talk at POSICon last year. So a little 1 centimeter incision on the medial border of the scapula as well, just to get the medial fibers of subscapularis. And then next thing I do after that is then harvest teres major and lat dorsi for my transfer. Once I've got that, the soft tissue stuff is ready to go, and I turn my attention to the bony stuff. So I look between infra and teres. I just release the inferior half of infraspinatus and I reflect it medially. And then we do a little capsulotomy parallel to the joint line so I can look inside and inspect the cartilage and inspect the sphericity of the head. And once I reduce the shoulder, that abduction contracture worsens most of the time. And in this setting, then we address that POSI sign as well by going to the medial spine of the scapula and lifting the supraspinatus of subperiosteally all the way to the spinal glenoid notch. You don't go, once you hit that, don't go any further. But I find it pretty effective in terms of addressing moderate abduction contractures. As Dr. McCombe said before, I've tried some arthroscopic capsulotomies as well, but I haven't been really too happy with that. And then the next step is to expose the scapular neck. I incise the periosteum in line, and staying subperiosteally, I put some baby homins on the superior and inferior aspect of the scapular neck prior to doing the osteotomy. The osteotomy is made parallel to the joint surface and at least 5 millimeters medial to the glenoid rim. I use K-wires to mark my line, and the wires are usually aiming for the coracoid. I do all the templating preoperatively off the axial imaging, and I have taken to using allograft bone blocks so that I can prepare my triangular wedges before undertaking the surgery to save some time. And then once I've got the osteotomy, I make sure that I don't go through the anterior cortex. I use stacked osteotomes and then a small laminar spreader to open it up and then tamp the wedge in. Once the bone block is in, it's relatively stable. It's a bit like the Pemberton or Degas type osteotomies that we do in the hip. And at that stage, I then lay my latissimus dorsi and teres major down onto the humerus into the greater tuberosity. As Dr. McCombe has mentioned previously, I find it a bit of a struggle, but lately I've been taking to using the lat dorsi more superiorly to act as the humeral head depressor. But I find it difficult to know where I put it. But I have to say that by doing a posterior approach, I can probably get a bit higher than I used to. Just closing the capsulotomy, I do that with the arm adducted and in external rotation, but I take care not to double breast my capsular repair, as we had a couple of overpowered external rotation deformities in Toronto. The deltoid is then sutured back down, and I've had no issues with the wound so far. They healed pretty well. And this is one of our little chaps demonstrating his improved adduction, even at the 12-month follow-up. Now, a big contraindication for me is a family or the patient who won't tolerate the spica or post-op physio. And the shoulder spica is not pleasant. I'm the first to concede that. We've been trialing different materials. I've used the chest piece from a Boston TLSO to try and make it a bit more comfortable for the patients. And in terms of position, I aim for maximal external rotation and as much adduction as I can get with that chest piece on to maintain the stretch on the subscapularis and to prevent worsening of the abduction contracture. I'm a bit torn about the elbow position. By flexing the elbow, I can get good external rotation, but I've noticed a worsening of the elbow flexion contracture. So now I try and only flex the elbow up to about 40 degrees, but we're still struggling with that. So what do they look like? All the kids get a 6-week, they get a preoperative CT as well as a post-op CT at the 6-week mark, and this is preoperative with the glenoid dysplasia and the subluxation of the humeral head up posteriorly. And then at the 6-week mark, you can see the graft up the back and realignment of the joint. And the head is at this stage still not spherical, and you end up with a pre-op and post-op picture a bit like this. All our children have been followed up with a MRI at the 12-month mark as well, and this is one of our 12-month MRIs. And amazingly, I've been pretty happy with the return of sphericity in the humeral head. So same right shoulder, again, you can still see the graft there, but enlocated with return of a spherical humeral head. So I have a very small cohort compared to Toronto, and we're still in the early days yet, but results are encouraging. On average, active external rotation with the shoulder down by the side in adduction has increased by about 45 degrees and 70 degrees in shoulder abduction. The glenoid retroversion has improved by, on average, 30 degrees. And so far, with a mean follow-up of 8 months, they've all remained enlocated. So external rotation osteotomies of the humerus have been and still are the standard of care for palliative osteotomies in children with irretrievable glenohumeral dysplasia. I think there is a small cohort in the 4, 5, 6-year-old who still have some remodeling potential where this is useful. And I think that the short-term functional gains so far are comparable to anything, to any osteotomies in the humerus. So in my mind, it's a viable alternative if performed on a very select cohort of patients and in conjunction with soft tissue rebalancing. So maybe we can consider putting the golf ball back on the golf tee. And that's mine. And Dr. Shah or Dr. Ganjwala, would you like to stop for some questions now? Or?
Yeah, so as we are actually running a bit late, I'll ask one question to David and one to you. David, how do you prevent external rotation contracture to happen when you need to extensively release anterior soft tissue or when you do subscapularis tenotomy? Because there is a very high rate of external rotation contracture in arthroscopic as well as open anterior release. So have you experienced that?
Well, I think what we've experienced is the patient. I presume what you're talking about is the patient who you do the external rotation. They were subluxed. You've reduced them into their anterior joint, and then they're stuck out like this.
Yeah.
I think the answer to that, we saw that a bit in the earlier phases. I think what's happened in our clinic over 20, 25 years is that we've sort of become more active at addressing the soft tissue issues earlier, as in the contracture around the shoulder earlier. Now, everyone, obviously there are kids who present late or slip through the cracks or who you thought were okay, and then a year later when you next see them, they've deteriorated, and so you're doing the surgery late. I think those children probably are the ones that potentially benefit from a glenoid osteotomy or ignoring the soft tissue procedure and going directly to a humeral osteotomy. I think this is absolutely a field where having each part of the armamentarium available, so say you get a individual recipe for each kid, is the answer. Because I think if you rely just upon soft tissue rebalancing, you will end up with a lot of those kids where you've reduced them, they've got a bad glenoid that's pointing way too posteriorly, and they're going to end up stuck out in an externally rotated position. And early on, when we had some of those children, they then came back and had internal rotation osteotomies. But I think if you use I think being vigilant, so seeing them frequently, trying to pick up when this problem is evident, operating early when there is still scope for remodeling, and before the advanced glenohumeral dysplasia is well established. And then if you get to the point where they've got that, using adequate imaging, so we use CT, MRI to fairly liberally now. If you can get an accurate estimate of what's going on with the glenoid, I would have a much lower threshold to a bony procedure if there's significant glenohumeral deformity than relying upon a soft tissue procedure. Because often, the concept of taking the hand away from the midline is a significant problem with these children. Usually the hand is not as able or capable as the normal hand. And if you take it away from the midline, you're really having a big impact on function. So I think, does that answer your question?
So I can understand why, you don't see many patients. We see very many neglected cases. So they come at the age of 6 years or even 10 years with type 4 glenoid. And then we have to do different glenoids and derotation. Now, there are a lot of questions, but I'll put only one question to both of you. If a false glenoid or Waters 4 present at different age group, what would be your algorithm? At till what age you would like to do tendon transfer and soft tissue release? Brian, at what age you would like to do glenoid? And at what age you will not consider both of it and go for derotation osteotomy?
You happy if I go first, Brian?
Yeah.
Initially, when I started doing these, when I trained in Leeds with Simon Kay and came back in the early 2000s, just as Bruce was taking over. And so I started doing the shoulder transfers after a return. And I would do the soft tissue because we didn't really have, at that particular point in time, we didn't have a lot of orthopedic input for various reasons. So we were relying upon the soft tissue procedure alone. And I think I operated on a lot of kids that I shouldn't have operated on. I either operated too late because I was worried I was going to do the wrong thing, or operated on children I shouldn't have. Now I think I would operate on a child's shoulder, early, as in a year, 2 years, 3 years, 4 years. I would operate on an older child if the glenohumeral relationship was really good. And that's a kid who has got a good shoulder anatomically on imaging. But I would, as soon as if I saw a type 4 with a pseudoglenoid, I'm very pessimistic about soft tissue rebalancing doing a lot for that child.
Yeah, Brian, your take.
So we have, so Dr. Shah, Dave and I, we've had a fair few discussions about this. You sort of sit and you look at the patient, you go, type 4, would you benefit? And I think in some cases, it's, especially in the older child, in the teenager, the one who comes at age 10, I think that's, there's no role for a glenoid osteotomy in that setting. I think your humeral osteotomy will give you the best outcome. And, in terms of the post-operative morbidity as well, trying to put a teenager into that shoulder spica is horrible. But if I look at it from a hip dysplasia analogy, I think, a redirectional osteotomy is almost great for kids about the same age as you do a Salter. So the 3, 4, 5-year-olds who are really demonstrating a Waters 4, their outcomes are going to be terrible. And it's worth giving a glenoid osteotomy a shot then.
Yeah. So thanks, David, for the honest talk, and thanks, Brian, for this information. Can we proceed to further talk now?
Maulin,
Sure.
Maulin, can I put in a word?
Yes, please. Okay.
Yes, please.
I feel we need to clarify a bit the analogy of the glenoid osteotomy to the hip is a bit exaggerated, according to me. The essential problem is the posterior slope of the glenoid because of the constant internal rotation contracture. That is the head of the humerus rubbing against the posterior glenoid and literally producing an eburnated glenoid. When you try to relocate that head of humerus by a soft tissue release, there is a very shallow anterior glenoid left. And that can never stay. It is the posterior capsule is already lax, and the head tends to fall back into that pseudoglenoid at the back. And what we are essentially doing is beefing up the posterior glenoid by osteotomizing the neck of the scapula so that more of the glenoid articular surface faces the head of the humerus. And therefore, it is not merely redirecting the shoulder. The shoulder still points backward, and therefore a subsequent derotation osteotomy of the humerus is almost inevitably required. We should be very, very careful in trying to produce an analogy between the shoulder and the hip. They're two different things.
Right, I agree with
Yep.
you. There is a time constraint. We cannot discuss this at great length. We can, but let's move on to other talk and
Sure, I'll share my screen, and
My name is Nicole and I'm a physiotherapist, and Rosie is an occupational therapist, and we are involved in the Brachial Plexus clinic at RCH. As we cannot cover all aspects of therapy today, we will give you an outline of our roles throughout different ages. We will be focusing on elbow flexion deformities and external rotation in our examples. We are involved in the initial assessment of referrals to the Brachial Plexus clinic. This allows us to assess most infants at 4 to 6 weeks of age to ensure reviews by our surgeons can be prioritised according to severity of injury. We continue to monitor and assess progress over time and complete pre- and post-operative assessments. Therapy post-surgical intervention, including Botox, is crucial in maximising outcomes for the child. Outpatient therapy blocks of 4 to 6 weeks are provided post-operatively and for those children requiring a dedicated focus on activity. We complete splinting and casting, which will be further discussed later. These are some of the assessments we use at RCH. For the AMS, a floor mat is used to place the child on their back, side, tummy and sitting to ensure that we assess across and against gravity movements at all joints. Accurately assess biceps and external rotation, the humerus can be held to the child's trunk by the therapist to isolate movement. Lightweight toys are used to engage the infant in moving. Children with brachial plexus palsy may have challenges rolling and in prone due to arm weakness, and therefore it is important to screen and facilitate normal development. There is no evidence to suggest an association between brachial plexus palsy and other orthopaedic conditions of newborns such as DDH, torticollis, and therapies, but given the increased birth weight in these children, many infants are screened at all new assessments. Goniometry measures need to be carefully taken to ensure accounting for compensatory movements. Videos can be used to assess functional upper limb use. This slide breaks down the aid ranges at which we typically use each assessment. This can vary depending on the child's ability to follow instructions and their comorbidities. We choose to use goniometry as soon as the child can reliably follow instructions, as we find this demonstrates change over time more accurately.
Therapists deploy many interventions across the ages. These include a focus on active and passive range of movement, which we monitor closely through growth spurts. We also use thermoplastic splinting as well as serial casting to improve or maintain passive range. With growth, we work on increasing core strength and strength of weaker muscles, such as triceps, which can also be done through aquatic therapy. At a young age, we teach parents to use modified constraint therapy and sensory feedback to incorporate the effective limb in play. Our teams have put together a parent information booklet that we distribute to caregivers during the initial appointment. This resource answers basic questions on the condition and provides ideas for developmental play, as well as demonstrating upper limb stretches that parents can complete. You can access a PDF copy of the resource on this link. Thermoplastic splinting is widely used across all age groups. Our most common use of splinting is to manage fixed flexion deformities in the elbow, especially during growth spurts. We start splinting the elbow at 15 to 20 degrees of elbow contracture, and splinting is used to improve or maintain elbow extension. Serial casting is used to manage an elbow contracture that is greater than 40 degrees. This involves weekly cast changes, then the fabrication of a thermoplastic elbow splint, after passive range plateaus in improvement. Following serial casting, the elbow splint is worn 23 hours per day and gradually reduced by 2 hours per week. We also splint to trial the effects of the surgery. This teenager loves basketball and wanted to know how a wrist fusion would affect his ability to catch and throw. We fabricated a wrist splint to mimic a wrist fusion, and he decided to proceed with surgery.
In infants and babies, our focus is on assessing muscle function and tracking change over time to identify children who may require nerve exploration. At this age, children may develop a preference to use their unaffected hand primarily, and modified constraint-induced movement therapy can be started. Tolerance of passive range of motion exercises can be improved through song. Tummy time is important to facilitate upper limb weight bearing and rounding of the humeral head. Here is an example of stretches through song, particularly into external rotation and supination, which are important stretches that children begin to resist around 12 months of age.
Like a teddy bear, head, shoulders, knees and toes.
This is an example of modified constraint-induced movement therapy. As you can see, the child is using a sock on their unaffected arm to encourage the affected arm use in play. The sock allows for the child to put weight through their arm for stability, but requires them to use their affected arm in play. If children have poor wrist and finger function on their affected side, this method of therapy is not appropriate as they will not be able to grip and release the toys. In preschool age, our focus is on correcting excessive compensatory movements and isolating muscle activity. The use of high back chairs or standing against a wall can help to prevent trunk rotation, which is a learnt habit for poor external rotation. Rowing activities and children lifting hula hoops to place over their head and body are used to facilitate external rotation. Repetition is important for motor relearning, particularly after surgical intervention. Passive stretching in this age group should be considered in supine to limit trunk rotation. Weight bearing on the arm in crawling can help shape the humeral head.
In school-aged kids, postural correction through the use of a high back chair and the reduction of compensatory movements should continue to be focused. At this age, we start to teach children how to complete their own stretches, but parent assistance is still recommended. We also start active strengthening of triceps with resistance bands and commence elbow splinting to address elbow contractures in this period of rapid growth. Participation in sport is highly recommended for socialization with peers. We encourage racket and ball sports such as tennis for external rotation, cricket for tricep strength, and gymnastics for upper limb weight bearing. At a teenage age group, they are encouraged to work towards self-management and adult-based responsibilities, such as learning to drive. Therapy should be targeted towards addressing residual impairments and increasing independence in self-care and daily activities such as grooming. Stretches should be independently completed at this age and continued as lifelong habits. Of particular importance are external rotation stretches and elbow splinting, as again, this is a rapid growth period. Students at this age are more desk-bound with study and often report shoulder pain. Advice on desk setup, postural awareness, and core strengthening are our main focus for this group. Low weight, high repetition of good quality movements are essential to building postural strength. We also address age-appropriate life skills, and common issues we encounter include grooming. This is a video of a girl who has very limited active shoulder range of movement, but passively has maintained enough range for functional use. She is demonstrating the use of her shoulder passive range to independently tie her hair by stabilizing her forearm on her knee. This is why it is crucial to maintain passive range even when active range is significantly limited. This also provides surgical options. For example, maintaining passive range of external rotation is helpful for consideration of a lat dorsi transfer. That's a snapshot of therapy at RCH with a focus on external rotation and elbow contractors. Thank you for your attention, and we would be very happy to be contacted via email.
Thank you.
Thank
Dr. Shah.
very much. This is Sandeep here. So to introduce Anil Bhatia to you, can you hear me?
Yes, please.
Hello.
Yes, please.
Yes. Yeah, please.
Hello. Yeah, so I was just inviting the hand surgeon from Pune and has spent about 25 years of his life doing obstetric palsy and adult brachial plexus reconstructions, from nerve surgery to nerve.
Sorry, I can't hear you.
You want
Anil, please start your lecture.
Yeah, for some reason I couldn't hear Sandeep for the last 5 minutes. All right.
Go ahead. Please go ahead with the lecture.
All right. Thank you very much, Dhiren, and hello to the friends from Australia. I have been advised that we are running out of time, so I'll just go very quick. I represent the Brachial Plexus International School, which is a joint effort between me and my friends from Asyut, Barcelona, and Guadalajara. Hopefully next year we'll include Wang Shufeng from Beijing. We select 3 practicing brachial plexus surgeons each year over the past 2 years, and it's a 1-week to cutting-edge surgeries, follow-up, and case discussion at each center. Therefore, it essentially the course involves extensive travel for each of the delegates, but 1 week at a time. Alex and I have both worked with Piero Raimondi, and we continue our very close relationship with him. This is a picture taken in January when I was in Barcelona. Our team members are Alex, Tarek El Gamal at Asyut, and Jorge Clifton at Guadalajara. And these are just a few snapshots of the course in 2018 in India. And this was in Barcelona earlier this year. This was in Asyut last year. So I will be focusing mainly on the aggressive attitude towards primary nerve reconstruction. As we know that the birth palsy is essentially due to a stretching injury of the roots of the brachial plexus in the neck, and the deficit can only be addressed by early nerve reconstruction in the cases where spontaneous recovery cannot be anticipated. And if deformities do develop, they should be addressed early, as we have already discussed. So we'll quickly go over the indications for nerve reconstruction in our practice here. The most common situation is a C5, C6 birth palsy, as we all know. But that is also the injury which suffers the least amount of injury. And therefore, the indication for surgery is a source of debate across the world. There is absolutely no debate when the deficit extends beyond this C5, C6. Therefore, an extended partial or a total palsy would be an automatic indication for surgery at 3 months. But a C5, C6 palsy, on the other hand, we have to be careful in offering surgery early. I rely, and as do my colleagues across the globe, on serial clinical observations, and we look at the overall progress in the shoulder abduction and elbow flexion. Now, there are a lot of trick maneuvers that the child develops as it grows, and therefore one has to gain experience by constantly observing them. I prefer to take videos whenever the patient comes for consultation, because it's very difficult to translate what I'm observing here into clinical notes and then revise that a month later. Therefore, keeping video records of each patient is very important. So this child, again, is followed subsequently, and you see that there is not much improvement in shoulder abduction. Now, this seems to be some abduction, but this is the pectoralis major, which is confounding the picture. Because if you take off the clothes, the same child has got practically no shoulder and elbow flexion. So the indication for surgery is entirely based on clinical evaluation. And according to Alex and I, a significant difference in the 2 upper limbs during the 4th month makes us, we have the inclination to offer surgery as early as possible. The cases where a spontaneous recovery at the shoulder and elbow has happened in the 5th or 6th month, as Waters' study clearly showed, the need for secondary surgery at the shoulder automatically increased, and therefore we prefer to operate very early. The surgical strategy is always by the anterior approach. systematic evaluation of the roots medial to the phrenic nerve, and excision of the scarred area. We use whatever is available from the proximal root stumps, if they are utilizable, with nerve grafting. Additional nerve transfers are added only when we feel that the nerve grafting will not be adequate. So let us look at a few examples. This kid presented at 2.5 months with this sort of picture. A month later, not much significant improvement at the shoulder and elbow. The hand was good, the triceps was good. Exploration showed this classic neuroma in continuity of the upper trunk. According to our protocol, we prefer to excise the neuroma and graft it. So we did I did a spinal accessory to suprascapular nerve transfer, which is systematic in my practice. And I utilized the available root stumps of C5 and C6 for the posterior and anterior divisions of the upper trunk. Now, the biggest problem I have in my practice is maintaining follow-up, and most of it is by videos sent by the parents. The mother is the best physiotherapist, and I prefer to, like the therapist talk earlier, I also prefer to train the mother to execute the actions as the child grows. Another patient presented at directly at 4 months with this sort of position of the upper limb. Again, 2 roots were found, which were utilizable, and a similar procedure was done. This is my only follow-up of this child. Between surgery and seeing this video, I had no follow-up at all. And yet, the quality of the surgery provided us this excellent result. Sometimes we do not have available root stumps, and therefore we have no option but to use nerve transfer. The child I showed earlier, when I operated at 4.5 months, the upper trunk looked good, but when I traced it medial to the phrenic nerve, there was no utilizable root stump. The C5 and C6 roots were avulsed. So I did the standard set of 3 nerve transfers: spinal accessory to suprascapular, ulnar nerve to biceps, and the long head branch of the radial nerve for the deltoid. Again, this child stays very far away, and I get only follow-up from videos. This is a video taken last week. And the quality of the outcome in such babies is incredible. It is difficult to determine which limb was affected. Now, when do we offer additional secondary surgery? In spite of systematic therapy, or if the patient presents late, if the external rotation in adduction does not improve beyond neutral, despite 2 to 3 months of focused therapy, then our standard procedure would be to first shorten the coracoid process, release the coracohumeral ligament, and based on the reduction of the head of the humerus achieved, we may or may not add a subscapularis slide from the body of the scapula. We prefer to go by an axillary approach and not by a posterior approach. And the axillary approach is adequate for providing access to the latissimus dorsi for transfer. So this child had an extended partial deficit, which I operated at 4 months. The C5 was ruptured, the C6 and C7 were avulsed. The C5 was bridged with nerve grafts to the entire upper trunk, and I added ulnar nerve to biceps and spinal accessory to suprascapular. During follow-up, I noted that the external rotation wouldn't improve, and the child had developed an internal rotation contracture. I'm going to let this video run for a bit so that you can see that there's an internal rotation contracture. It's difficult to get a child to cooperate at that age. You can see that the shoulder is rotated internally completely, and passive external rotation wasn't possible. So I chose to do the procedure described a bit earlier. And this is the video taken last week. Again, these sort of tricks to encourage movements of the shoulder by sticking clips on the clothes, I have found very useful in encouraging the child to use the upper limb. For total palsies, the focus is essentially to get hand function. In our experience, we find most often 1 or 2 root stumps available for grafting, and these are systematically directed towards the lower trunk in the neck, and we utilize nerve transfers to get the shoulder abduction and that is the innervation of the rotator cuff and of the biceps. Intercostals are the basic nerve transfer that we use for elbow flexion, and it has worked in almost all our cases. So this is just to illustrate what we do in most total palsies. We'll look at this example. This child had come at 6 months with some spontaneous recovery in the biceps, but the rest of the upper limb was flail. As I said, we take down the plexus and we bridge the available root stump to the lower trunk and use the nerve transfers. So here I found 2 nerve stumps, C5 and C6, and both were directed by nerve grafts to the lower trunk. Again, follow-up is an issue for me. The child stays about 200 kilometers from where I practice, and this is my only follow-up after 2 years of the operation. But you can see that the shoulder abduction and external rotation has come. I have not examined the patient clinically myself. This is the video that the parents sent. But what is more important is the quality of the hand function. I'm going to let the video run. You'll see. It's wonderful that nerve grafting in the neck from 2 roots provides sufficient axon material to produce both finger flexion and finger extension, extrinsic finger extension, which is most difficult to restore in a total palsy. Of course, when I get better follow-up after the lockdown ends in India, I will be able to address the various issues that the child is facing. Finally, we do unfortunately get patients who have never been treated since birth. They have systematically been followed up by a variety of surgeons, but no surgery is offered. And this girl came directly to me at the age of 24. So obviously we have only salvage to offer, and I did a free gracilis with spinal accessory for restoration of elbow flexion, and then subsequently added shoulder and wrist fusions to improve the utility of the upper limb. This lady had never used this hand at all till the age of 24. And she is such an intelligent girl that she was able to send this video from her place of work, how she uses the arm in her daily work, daily activity now.
Anil, can you wind up with your message?
Yeah, this is the last video. That's it.
Thank you. Thank you.
So I thank the Paediatric Orthopaedic Society for the opportunity to participate in this symposium. Thank you very much.
Thank you very much. Thank you. So with this last talk, because we are running short of time, I don't think we'll be taking questions, but you could contact all the speakers individually. I must thank the Royal Children's Hospital, Melbourne Comprehensive Care for OBPP department, well put together by Brian Lowe, Dr. Johnson, Dr. McCombe, Dr. Wilkes, Dr. Alexander, and Dr. Ko. Thank you very much for that comprehensive talks to give us an overview of how you are managing brachial plexus Palsy. And thank you, Anil Bhatia, very much for emphasizing and showing the people from Melbourne also the kind of neglect and the resource crunch that we have, where one person is doing nerve surgery, nerve transfer, bone surgery, and rehab using clips. So you are all in one. And we have a few of us like Maulin, who's also trying to establish a brachial plexus center, and Rujuta Mehta at Wadia Hospital. So for a country of 1.2 billion, I think more people should be taking interest in OBPP and learning how to manage these children, because we have a really huge volume. Anil, I hope you can also train POSI members who would like to come in for your international school, and hopefully they can visit Melbourne to learn the international approach too. So thank you very much. Thanks for sparing your time on a Sunday afternoon.
Thank you.
Yeah,
Thank you.
thank you,
Thank you for your hospitality.
everyone.
Thank you. Bye-bye.
Thank you. Yeah.
Thank you, Dr. Bhatia.
Thanks. Bye.
Cheers, Marlon. Thanks, Anil.
Yeah, bye. Bye. We'll be in touch, David. Those were honest talks. Thank you.
Thank you,
No
everyone.
worries. Anytime. Thanks, Anil. That was very informative.
Thank you.
Cheers. Bye-bye.
Bye.